And then now we can move to the second discussion about the role of consolidation and maintenance therapy in the transplant setting. Consolidation therapy is by definition short-term, which is aimed to improve the rate of response and to induce the deepest level of response after the previous treatment phases, including induction and autologous stem cell transplantation. Before the novel agent era, high-dose melphalan, either single or double with autologous stem cell support, has been traditionally considered the standard consolidation therapy for transplant-eligible myeloma patients. Over the last few years, the novel agents have shifted the treatment paradigm for transplant-eligible myeloma patients, are currently part of induction and maintenance therapy before and after autologous stem cell transplantation, and more recently have been investigated also as part of consolidation therapy. And you can see summarized in this slide several of the novel agents which have been explored either as single agents or combined with one another as consolidation after single or double autologous stem cell transplantation. My first question to Dr. Heinzele is if the whole concept of reserving a second transplant only to patients who failed at least VGPR or near CR should be revisited by applying a second transplant in the novel agent era, in which the goal is not to achieve a conventionally defined CR, but the deepest level of response up to the immunophenotypic or molecular negativity.
Yeah, I think this is a very important question. There have been 2 studies in the past that showed that patients benefited from a second transplant if they didn't achieve a very good partial or complete remission. These were the patients that actually benefited from the second transplant. But both studies were done at the time when the novel agents were not available for induction, consolidation, or maintenance. And thus, I think it's high time to reconsider the tandem transplantation concept in the era of the novel agents. And as you indicated, it is already tested in several trials. So there's a US-American trial and also a European trial that are looking at the role of a second transplant in the situation of an induction treatment with novel agents, in the situation of a consolidation and maintenance with novel agents.
Yes, okay. And I would like to ask to Dr. Attal to briefly summarize the results of several recent trials in which a triplet bortezomib-based regimen in which bortezomib was combined with an IMiD such as thalidomide or lenalidomide as a consolidation after a single or double autologous stem cell transplantation.
Today we have at least two big trials using these kinds of consolidation treatment with these triplet drugs, VTD or VRD. I would say that in both trials, the impact of 2 or 3 cycles of this consolidation was found to be dramatic. For example, using VRD, we can obtain roughly 60% of very good partial response after transplant using a proper induction with VRD. And this rate of very good partial response can increase up to 86% after consolidation. So in this trial, in this particular trial, the impact of consolidation is huge, and you observe, of course, the same results with your VTD trial. So today, I think we can say, we can agree that the use of consolidation after transplantation is for sure able to improve the very good partial response rate, the complete response rate, and the stringent complete response rate. The question we still have to face is to know if this improved complete response rate will be associated with improved PFS or overall survival. We have to design trial to do so.
And Dr. Sonneveld, what about the most recent data using bortezomib or lenalidomide as a single agent for consolidation therapy after transplant?
Well, I mean, one of the first examples of using bortezomib after the autologous transplant was from Dr. Attal's trial, where he used bortezomib very early on. But more recently, I think there are two trials that used bortezomib or lenalidomide dex for early consolidation. The last one was again performed by the IFM using len-dex followed by maintenance or by placebo, clearly showing an impact on the response and the quality of the response with the consolidation treatment. The Nordic Myeloma Study Group has also performed a study using bortezomib for 20 gifts after the transplant as a consolidation treatment. And what they showed is that there was again an upgrade of response in those patients compared with the control group, and also a significant increase in progression-free survival. So far, not yet an impact on overall survival, but this may be due to the relatively short follow-up at this time. So taken together, I think both lenalidomide and bortezomib have an impact as consolidation treatment after the autologous transplant.
Thank you. I think that we can summarize the first part of the discussion, claiming the ability of the novel agents to improve the quality and the rate of response after prior induction, including novel agents and subsequent subsequent autologous stem cell transplantation. In several trials, consolidation was able not only to improve the rate of response up to conventionally defined CR, but also to deepest level of response up to molecular negativity. And in two of these trials, data suggested also progression-free survival benefit from consolidation therapy versus no consolidation, or in another trials versus a doublet not bortezomib-based consolidation therapy. Nevertheless, as it is stated in this slide, at this time consolidation therapy should still be considered an investigational approach, and as previously mentioned, we need prospective randomized clinical trials specifically designed to evaluate the impact of consolidation therapy on progression-free survival and overall survival. Another burning question is if there is an optimal number of cycles to be used as a consolidation therapy, and I would like to ask to Dr. Blade to address this question.
Well, as you mentioned, the concept of consolidation is to increase the degree of response after induction plus hydrotherapy, perhaps in a damaging myeloma population in the marrow already affected by the transplant, etc. And the concept is to decrease the tumor mass with a limited period of time and full dose regimen, and should be full dose regimens for 2 to 3 cycles. Probably 2 would be enough.
And I would like to ask to all the panel if they agree that progression-free survival is an acceptable endpoint for investigating the value of consolidation therapy with novel agents, or if they think that overall survival should be reached. I do realize that it is not easy, because in many trials consolidation is subsequently after consolidation there is a subsequent maintenance therapy with novel agents, so it is not easy to dissect which is the impact of different treatment phases. However, on a philosophical point of view, do you think that PFS is enough?
Well, I think there might be a debate about this. In the perfect situation, I think overall survival should be the appropriate endpoint, because we are exposing patients to extra treatment, so this should translate in a better overall survival. However, in practice, patients receive not one, but they receive several treatments. And so it's very hard to evaluate what the effect of consolidation treatment will be on the overall survival, and we have to take progression-free survival as a surrogate endpoint.
So, do you agree that the PFS is an acceptable treatment point for evaluating the role of consolidation therapy as suggested, and with all the limits of reaching a survival benefit in the novel agent era, with many and many new treatment options to be used at the time of relapse?
I think, well, I would agree. The consolidation treatment is a treatment of short duration, 2 or 3 cycles, probably 2 cycles are enough. And during this period of 2 cycles, the occurrence of resistance to this drug is unlikely. This patient will relapse 1 or 2 years after this consolidation, and this patient will probably still be sensitive to the drug used for consolidation. So I think PFS could be a major endpoint, and overall survival is not required, since it will be very difficult to observe. So yes,
I would agree. I could add also that we have to look not only at the medians, progression-free and overall survival, but also to the tail of the curve to see if we can increase the proportion of long-term survivors and operationally cured.
Dr. Michele, Dr.
I think the
do you agree?
consolidation has one advantage. It's short time, so the patient are exposed to a drug that causes side effects only for a short time period, and consolidation has the aim to improve quality of response. So we can measure something, and we can tell the patient he is responding to the consolidation, which will motivate the patient to undergo consolidation. I think that's one of the major differences when compared to maintenance, and therefore I think for consolidation, progression-free survival is a good endpoint, yes.
Do you agree?
I can agree with the previous thought.
So we can conclude that up to 3 cycles of consolidation therapy can be given to improve the rate and quality of responses after prior novel agent-based transplant, and that PFS is an appropriate endpoint to evaluate the value of consolidation in the future clinical trials which are currently running aimed to address this issue. And now we move to maintenance therapy, which differently from consolidation has been traditionally considered a long-term therapy given with the objective to reduce the risk of relapse or progression with the aim to prolong progression-free survival and overall survival. We have at this time different treatment options: thalidomide, lenalidomide, bortezomib, eventually with the addition of an IMiD. I would like to remind that both bortezomib and lenalidomide are currently still under investigation, while thalidomide is reimbursed in several European countries but is not formally approved as maintenance for transplant-eligible myeloma patients. Coming back to the prior question about consolidation therapy, that is, moving from consolidation to maintenance. Progression-free survival should still be considered an appropriate endpoint, and I would like that Dr. Attal should address this question.
In my opinion, no. PFS is not the appropriate endpoint for maintenance. Indeed, if you use an effective agent as maintenance treatment, you will prolong the duration of your first response, and so you can improve your PFS. However, for sure, when the relapse will occur, if this patient is still treated with this maintenance drug, these patients will become refractory to this maintenance treatment. So what you have gained during the first part of the use of this drug, you will lose it after a time of relapse. So in my opinion, concerning maintenance, we have three different situations. The first and the most important and the most interesting situation is an agent able to improve overall survival. In this case, this agent, of course, should be recommended. The second option is a treatment failing to improve the overall survival, but associated with an improved progression-free survival and without any toxicity. In this case, this agent, of course, won't improve the overall survival, but this agent will be associated with an improved quality of life during the maintenance period. And in my opinion, in this case, this agent should also be accepted. So improve PFS without toxicity, improving quality of life. We also have the third option. In this option, this agent evaluated as maintenance treatment has failed to improve overall survival, is able to improve progression-free survival, however, is associated with significant toxicities. In this case, this won't be associated with an improved quality of life, since during the maintenance period, this patient can experience different toxicities, different side effects. And so in this situation, an agent associated with an improved PFS with significant toxicity, in my opinion, should not be recommended as maintenance treatment, but its use should be postponed at time of relapse.
We previously mentioned that maintenance should be given to reduce the risk of relapse or progression while maintaining a good quality of life. So the issue of quality of life, the issue of adverse events related to novel agents as part of maintenance therapy is important. We previously mentioned that the maintenance is aimed to prolong progression-free survival and particularly overall survival while maintaining a good quality of life. Therefore, the issue of tolerability or an adverse event is of particular relevance. And this is true for thalidomide among all other novel agents, given the access and reimbursement for this drug in many European countries. I would like to ask to Dr. Sonnenfeld to briefly summarize the status of the art concerning the major adverse events seen with the novel agents, either as recommended treatment and also as part of investigational clinical trials.
Well, as Dr. Attal said already, if you want to use maintenance, it should result in a gain of progression-free survival and also overall survival. If you cannot do that, it makes no sense to give maintenance treatment. And I want to illustrate this point with the HOVON G trial that compared thalidomide maintenance and bortezomib maintenance for 2 years. In the thalidomide arm, only 26% of the patients were able to complete the full 2 years of maintenance, which makes thalidomide not a good candidate for maintenance because it's not tolerated. With bortezomib, this was much better. Bortezomib given every 2 weeks was tolerated in more than 55% of the patients. at full dose and an additional 10 or 50% at reduced dose. So bortezomib maintenance with bortezomib in the induction resulted in an overall survival benefit in this trial. And I think this is what we should aim at when we design maintenance trials. Also, I think lenalidomide is a good candidate. Usually it's well tolerated, and so far we have not seen overall survival advantage, but we have seen PFS gains, and maybe with longer follow-up, also an overall survival benefit can be observed in some of the trials that have been concluded. So I think tolerability is the key word here. If patients can tolerate the treatment, you may have an effective additional way of treating these patients.
Dr. Antila, do you agree that neurological toxicity is the major caveat precluding a widespread acceptance of thalidomide maintenance in the daily clinical practice, although at this time it is the only novel agents clearly approved for this indication?
So I think so. The neurologic side effects are certainly the most important side effects which cause you to go on or go off from the maintenance program. So there might be some others, so the fatigue, so some other things too, but neurological problems are the most important regarding thalidomide.
Another important issue is if we have enough data to identify those patients who mostly benefit from maintenance therapy. And I would like to ask to Dr. Bladet to address this question and to try to identify the best profile of the candidate to receive a maintenance therapy with the novel agents.
Well, in the transplant setting, the problems with thalidomide, particularly the peripheral neuropathy, has been emphasized, and also the possible negative effect on patients with deletion 17p. So thalidomide is not a good candidate for maintenance mid-long term. Having said that, I believe that the transplant candidate should be offered an optimized therapy as a total therapy, including best induction, high-dose therapy, consolidation, and likely maintenance in order to have the best results at the end of the 10-year survival or so. And then we have now identified clearly subgroups who can benefit, so we have to give probably to all patients, all are candidates for maintenance, probably perhaps not with a single drug, lenalidomide. Len plus one glucocorticoid could be the backbone, and then perhaps compare these with a third agent, new agent, probably oral or with good tolerance for up to 2 years or so.
You previously mentioned that the issue of cytogenetic abnormalities in patients exposed to thalidomide. What about the disease status before receiving maintenance?
The disease status concerning response.
The response to the previous treatment phases. In other words, a patient in CR is a good candidate to receive maintenance, or should we reserve maintenance to patients failing CR?
I would start maintenance in all patients with the assumption that we have not yet cured the disease, and for example, in our future PETEMA trial, we plan that maintenance for all patients up to 2 years, and up 2 years stop maintenance in patients with negative minimal residual disease by flow cytometry in order not to overtreat patients, and then maintain the remaining until progressive disease.
Okay, moving from this last assumption, do you agree that the old concept of a maintenance therapy given indefinitely until relapse or progression should be revisited and we move forward to a fixed time period of maintenance? Dr. Attal.
That's a very, very important and difficult question. First of all, I think that we are always mixing this concept of consolidation and maintenance, and trying to, for example, to obtain results of maintenance, which in fact are should be results of consolidation. So I think really for me the main question now is to know if a patient with a true complete response, a stringent complete response, really benefit from maintenance. And this would be the real demonstration of the concept of maintenance. In a patient without any residual disease, is it interesting to maintain? So this is the first question. Now, the duration of maintenance, well, it's difficult, but obviously it's very difficult to use a treatment for years and years. It's very difficult, and practically it's not done by patients or doctors. Furthermore, if you prolong your duration of treatment, even if the treatment initially is well tolerated, you can expose this patient to side effects. For example, with Revlimid, we observed that after 2 years, we can observe an increased incidence of DVT, an increased incidence of infections, and of course of SPM. So I think it could be probably wise to limit the duration of maintenance. However, once again, I would like to really ask this question in a patient without detectable residual disease.
Dr. Heinzel and Dr. Sonnenfeld, do you agree, especially in the light of the possibility that a prolonged exposure might favor the selection of tumor-resistant clones at the time of relapse and of a shorter survival after relapse due to a less favorable response to salvage therapy?
I think that's a clear concern about maintenance treatment, that by exposing tumor cells for a long-term period to a drug that is probably also given in a suboptimal doses, that this could induce resistance. And I think this is one of the major issues we have to investigate in all our maintenance trials. And especially looking at the thalidomide maintenance studies that are already published, we know that in 6 studies there is a prolongation of progression-free survival, but only in 2 or 3 a prolongation of overall survival. And in 3 studies it was clearly shown that by thalidomide maintenance you induce not only resistance to thalidomide but to any salvage treatment, reducing the time of remission after progression following maintenance treatment. And I think this is a major concern which has to be carefully addressed in future studies.
Dr. Sonnenfeld, would you like to add something?
I agree with Dr. Heinzel, and I would like to add that in the trials we have to carefully examine the tumors, both at diagnosis of course, but also at relapse, and to see what are the molecular and phenotypic changes that occur from diagnosis to relapse, in order to, let's say, to realize what's really happening, and maybe in the future adapt our strategies to that knowledge.
So we can summarize that the maintenance therapy is an important treatment phase of the new paradigm for transplant-eligible myeloma patients. Thalidomide is actually reimbursed in several European countries, but in spite of this, it is not widely accepted in daily clinical practice, mainly due to the neurological toxicity. And I think that all of us do agree that the whole concept of prolonged maintenance until disease progression should be revisited, and that a fixed time period might be useful, although probably we need again to design prospective randomized clinical trials in order to evaluate the role of a fixed versus a prolonged maintenance. I would like to thank you for the discussion.